I would like to now thank you all very much for attending our end of year event. The community that we've established is very much a part of this association, and I'm very pleased to introduce Professor Anne Kelso, who will do an official open. Professor Kelso is probably known to many of you in Australia and New Zealand. Following her PhD at the University of Melbourne, Professor Kelso undertook research in immunology at the Swiss Institute for Experimental Cancer Research and the Walter and Eliza Hall Institute of Medical Research and the Queensland Institute of Medical Research. From 2000 until 2006, she was also Director and CEO of the Cooperative Research Centre for Vaccine Technology. She then returned to Melbourne as Director of the WHO Collaborating Centre for Reference and Research on Influenza from 2007 until she took up her role with the NHMRC in April 2015. She was appointed Officer in the Order of Australia in June 2007 for service to science. Professor Kelso is a member of several government and international committees, including the Australian Medical Research Advisory Board, the Board for the Global Alliance for Chronic Diseases, and the Board of Trustees of the International Human Frontier Science Program Organisation. Professor Kelso will be speaking on health services research funding within the NHMRC. Thank you very much, Anne.
Thank you very much, Rachel, and good morning, everyone, or good afternoon to those who are joining us from New Zealand. I'm really delighted to be with you today for this session. I'm joining you from Ngunnawal country in the ACT, and I also want to acknowledge the traditional custodians of this land and all the lands on which members are joining this meeting today. So I'm very pleased to be able to say a few words at the beginning of this session, and I don't know what I need to do to officially open the session, but perhaps I could just say the session is now officially open. So I'm now going to share screen and just show you a few slides to talk a bit about NHMRC and in particular research funding for health services research from NHMRC, which I know will be a topic of interest to many, perhaps most people on this call. And I also want to acknowledge and thank Rachel for the meetings that we've had and what I've been learning about the work of this society and health services research overall in Australia and New Zealand. So I'll share screen now and hope that this works. Does that look right to you? Good, thank you very much. Good, thanks. First, let's see if it actually goes forward. Yes, here we go. A few words about NHMRC itself in case you don't already know this. We have a number of roles which are legislated. We're part of the federal government health portfolio, and we think of those roles under three broad headings: investment, translation and integrity. And of course, health services research is particularly important for the first of those two. We invest in health and medical research through funding we receive through the federal budget every year, and some of that goes to health services research. I'll talk about that. But we also support translation of research into evidence-based health practice and policy, and I think that's an area where, of course, health services research plays a crucial role. I won't talk about the other elements of that slide, but I will just make a few general remarks about our approach to funding health and medical research. Our goal is to support research across the full spectrum of Australian health research needs. So that means from discovery research in the laboratory through to research in the clinic or research involving humans, whether it's in the population or in clinical trials, and community-based research. And of course, research within our health service delivery arms of the health system. We fund research that is investigator initiated, and most of that is bottom up in the sense that our schemes are very broad and it's really up to researchers to decide what to present to NHMRC to seek funding. Some of our research funding is targeted or top down, where we set the topic, if you like, but we're still seeking investigator-initiated applications. We're not pre-directing the funds to a particular group or a particular investigator. So it's a very open system. And importantly for that, all the funding is contestable through open competition with the outcomes determined by peer review. So the way our strategy rolls out is effectively in the way we distribute funds across the different schemes and the broad goals of the different schemes that are part of our program. We support both research projects and people, and when we support people, we do that at the level of the individual, at the level of teams, which might be small or large, and also national networks. And we seek to complement the work of the Medical Research Future Fund, and that's an evolving relationship between these two very important national funders, but I think an increasingly resolved and well-described alignment and complementarity between NHMRC and the MRFF. Overall, what we're attempting to do at NHMRC is to build and maintain the foundation of Australian health and medical research capability so that we have that capability both for what we need for the immediate problems of the Australian population, but also for what we can foresee of the future health challenges. And so the overarching goal of everything we do in research funding and in our other activities is to improve human health. So to go specifically to funding for health services research, now this just shows the breakdown for 2020 as a recent year, but it's pretty typical of recent years. And you can see, looking at applications or grants or the total value of grants, health services research is the smallest of the compartments that we ask researchers to identify their research in, whether it's basic science, clinical medicine and science, health services research, or public health or population health research. So health services research is the smallest segment, but it's good to see from this slide that grants and total value are greater than the proportion by application. If you look at our individual schemes, then, and this just shows data for the last two complete years, 2021 is still in progress, but 2019 and 2020 are complete. There's health services research funding across all of the major schemes, but the proportion of that scheme funding that goes to health service research is highly variable, and it's really obvious here from the shaded blocks that there are some schemes where health services research routinely takes a much larger proportion of the funding than other broad research areas in relative terms. So the standout there is partnership projects. This scheme fits very well with health services research, and over many years, including 2021, health services research has received a good proportion and in many years the largest proportion of partnership project funding. Centres of Research Excellence have a targeted stream for health services research, and so by definition and appropriately receive a significant proportion of funding there. And you can see that in the first round of Synergy grants, 2 of the 10 $5 million projects went to health services research. So this is variable from year to year, but shows the areas of strength where NHMRC schemes fit very well with health services research. And so then, just in a final data slide, this shows on the left, since 2015, the number of grants that we've awarded and the total value of those grants on the right-hand axis, and then health services research grants and value in the right-hand figure. So a couple of things to note from this. Overall grant numbers from NHMRC have dropped in the last 3 years, but that's because we've gone to a new grant program which has consolidated a lot of funding, so has deliberately reduced the number of grants, as well as the fact that our budget is stable, but grant sizes are tending to grow as people are requesting larger budgets. And there's a slight rise there in the overall value of grants being awarded, particularly this year, because we have some unspent funds that were carried over from last year when we slowed things down because of the pandemic. But what you can see from the right-hand side, and I think this is really encouraging, is to see overall that, particularly compared with total funding, health services research has been receiving increasing numbers of grants and an increasing proportion of our total expenditure. So I think that shows a direction that I'm sure participants in this call will want to see continue. So just to make a few concluding remarks before we move on to the highlight of this morning session and Don Nutbean's talk. To summarise, health services research receives significantly less funding than the other broad research areas that are funded by NHMRC. But the distribution of that funding varies a lot between schemes, and health services research is most competitive for partnership projects and centres of research excellence where there's a dedicated stream. I think it's good to see that both the number and the total value of health services research grants have been rising over these last years as a proportion of all of our grants. So there will be a few things to watch out for over the next little while that are going to be, I think, relevant to your part of the health research sector. First of all, the Research Translation Centre initiative. This has been going for a few years now, and it's a very important initiative from our point of view in the sense that it's seeking to embed research within healthcare, and this is really where health services research needs and should and can play a critical role. So participate in those centres wherever you can if you aren't already. I think they're an important pathway for the future. NHMRC is developing a research translation strategy, and it's going to be thinking about health services research will be part of the thinking as we develop that strategy. So there'll be more to say about that over the next year or so. And then we place a lot of emphasis on these broad research area definitions, and the data I've just shown you depend on people ticking a box that says that their research application is in the broad research area of health services research. But we don't provide a clear definition of those broad research areas, and we don't have any quality control really or assurance over the data we receive that way. And so I think this is a real impediment to us developing good policy to support health services research through NHMRC when we don't have we can't really have deep confidence in the data quality. So an important piece of work over the next little while will be to establish and refine the definitions for the broad research areas and ensure that we have better data quality for the future as we develop further policy. And then if I think about what you as a society can do for the Australian researchers who are wanting to be competitive for NHMRC funding, I think there are a couple of things to recommend. The first is please nominate to be a participant in our peer review process. That ensures that we have a large pool of researchers who are truly qualified to assess health services research grant applications that come to NHMRC. And I know that when people are concerned that their particular field or topic doesn't receive enough funding from NHMRC, then it's common to say, well, we don't have the right peer reviewers. We rely on people nominating to participate in peer reviews, so that's one way that I think this society can contribute. But also, I think when I look at how successful some groups are around the country, there's a lot to learn from each other about how to be competitive for NHMRC funding, and I strongly recommend that people share their experiences and learn from those who really are most competitive for NHMRC funding. Well, there's a lot more that I could say, but I think it's important to get on with the main game this morning, and I'm very happy now to finish that presentation and stop sharing and then go on to introduce Professor Don Nutbean, who's going to give the main talk now. I've known Don for a few years now. I've always greatly enjoyed interacting with him. I've always learned a lot from him, and I'm very pleased to have the opportunity to hear his talk this morning. Don is the Executive Director of Sydney Health Partners, which is one of the NHMRC Research Translation Centres, and he's a Professor of Public Health at the University of Sydney. His career has spanned an extraordinary range of roles, so he brings deep wisdom to these topics. He's had senior leadership positions in universities, government, health services, and international organisations such as the World Health Organization and the World Bank. He was formerly Vice-Chancellor of the University of Southampton in UK, Provost of the University of Sydney and Head of Public Health for the UK Government. He's a public health scientist with interests in social and behavioural determinants of health and in the development and evaluation of public health interventions. Don's current research focuses on the development and testing of interventions to improve health literacy in different populations. Now, Don's speaking today as a professor of public health rather than as a provost or in any of his other leadership roles, about his experiences in the role of health services in addressing inequalities in health from the UK and Australia. And I think these comparisons are going to be extremely interesting for us. He'll reflect on where health services research has been helpful in advancing practical action. And so the title of his talk is Observing or Engaging: The Contribution of Health Services Research in Tackling Health Inequalities. So after Don's presentation, we'll have some time for discussion. So as Rachel said before, please put your questions in the chat so that I can see them there. And now it's a great pleasure to pass over to Don, and I'll look forward to his talk. Thank you.
Thanks very much, Anne, and thanks to Rachel for the introduction, a very generous introduction. Thank you very much, Anne. I'd also just like to acknowledge the traditional owners of the land on which we're all meeting. In my case, like Rachel, I'm on the land of the Gadigal people of the Great Eora Nation, and I'll pay my respects to elders past, present and emerging, and of course particularly acknowledge any Aboriginal and Torres Strait Islander people who are with us today. I thought it was very generous of Rachel to invite me to speak to you today. I couldn't, under any circumstances, claim to be a health services researcher, and there is this desperate risk I run that I shall tell you all how to suck eggs. But as Anne has indicated, I've had an odd mix of experiences in my career, one of which was to actually try to develop through government an all-of-government approach to tackling health inequalities in the UK. And I wanted to offer some observations from that experience today and eventually land it by posing back to you some of the challenges that health services research might help us to address. And to challenge all of you to decide whether you're going to be an observer or someone who's engaged in solving the problems. With luck, I'll be able to share my screen with you. Just bear with me. There we go. So I'm a huge fan of the AIHW website and make great use of it for almost everything that I do. It's incredibly well organized. It provides really outstanding data and helps us all to understand what it is that challenges our health system and how we might be thinking ahead as to what the health system of the future looks like. Like I suspect some others here, I'm on the board of one of our local health districts in New South Wales, and I'm constantly challenged both by the present demands on our healthcare system and on the future shape of that healthcare system. This is an extraordinary resource that can help us think through some of these things. So I've just picked on a really helpful chart describing the major contributors to the burden of disease in Australia. Gives us a decent picture of what are the major causes of ill health in Australia, and how is that profile changing over time. It's a really good thing to look at, but doesn't really tell us too much about inequalities. It gives us a universal picture of the population as a whole. But of course, I'm sure you're all aware that if you dig into these data, you can start to understand what's driving things as opposed to what you can observe up front. And there are a number of different ways in which we can look at what's driving current disease burden and future trends in disease burden. And one way we can look at that is, of course, a very traditional looking at risk both behavioural and environmental risk exposures, classic way for someone like me with a public health background to look at things. And we can start to think about interventions on that basis. And one of the more obvious interventions here, for example, is to try to reduce the use of tobacco in Australia. And actually, we've been really rather good at that. The second one there is to try to reduce overweight and obesity. And frankly, we've been abysmal at doing that over the past 20 years. But it gives us a way of looking at the problem and a way of designing interventions to tackle the problem. But wait, there's more. Of course, there are other ways of looking at what contributes to the disease burden in Australia. And again, the AHW website provides us with information on how being part of different socioeconomic groups, different core populations, being Aboriginal, seems to be very closely related to disease burden, and again offers us a quite different way of looking at, well, how might we address the problem? And of course, if you look at it from a social and economic perspective, of course, firstly, you see a very significant variation in disease experience in Australia by socioeconomic group, and also a rather complex picture of how you might respond to it. In all of this, of course, I'm sure those of you online will be thinking about, well, where does the health system fit? But bear with me, I really hope I'll get to that in due course. The last way of looking, observing, as I've put it there, the challenge that I want to mention this morning is of course, to look at the impact that health services have directly on health status in Australia. And there's, again, some really good resources that have become more routinely, maybe made more routinely available in Australia in a really outstanding way, I might say, internationally. And there's the Atlas of Healthcare variation that highlights a whole range of different ways in which you can ask the question about what contributes to disease burden. And of course, access to healthcare is a really important driver, perhaps not as important as some of the other social and economic variables and some of the individual risks I've highlighted, but nonetheless, a significant factor. And I've picked on two issues that I know will be of great interest to many people online: simple access to health services and the variation that exists between and within parts of Australia, so between remote and regional areas and metropolitan areas, and also within metropolitan areas, for example. And there's also significant unwarranted variation in healthcare that can be observed. This seems to indicate that some people are having both unnecessary and, in some cases, potentially harmful tests or treatments, while others are missing out altogether on really important interventions. But again, I have to put it to you that we're still observing here, and there's a lot of research that can be done to refine the way we observe inequalities in health. What I wanted to do in the brief time I have available to you this morning is to talk about an experience I had in the UK when I was the head of public health for the then Blair government. In my case, I was working with a very junior and inexperienced minister, Yvette Cooper, one of the smartest people I've ever worked with, I have to say, as the newly minted Minister for Public Health in the United Kingdom. And I want to see if I can extract from that experience some things that might have relevance to our current circumstances in Australia, and in particular, set an agenda for health services research going forward. So I'll spend a bit of time, I'm going to have to do it very superficially and very fast, talking about an extraordinary programme that I was a part of in the UK, focus in particular on the role for the health system in addressing health inequalities in the context of that broader programme, explore with you some of the things I wish I'd known at that time and still don't believe we understand enough of in relation to the contribution that the health system can make to addressing inequalities, and then depressingly lament the lack of funding and systemic obstacles that get in the way of getting this work done. The reason I brought up Yvette Cooper early on, apart from the fact that she looks impossibly young for someone to be a minister, she is obviously a bit older now and is actually the Shadow Home Secretary in the UK, is I went directly from an academic role as the head of the School of Public Health at the University of Sydney into becoming the head of public health for the UK government. This is going to sound terrible. At around the turn of the century, I did this. And it required a very significant adjustment, I think it's fair to say, but I was still very confident in my skill set, and I recall vividly the first occasion I met with Yvette to provide her with the first briefing that I'd ever provided a minister as a civil servant, as I was then, and it was actually on the emerging epidemic of overweight and obesity in the UK. In my humble opinion, it was a superbly written brief. Succinct, contained on one side with some clear conclusions and recommendations for the minister. And Yvette read this in 30 seconds and said, brilliant exposition of the problem, but you haven't given me a single solution to the problem. So great observing, but actually no solution to my problem. And she then, when I got to know her a bit better, she said, you know, one of the problems I face constantly as someone who's genuinely committed to using the best available evidence to inform our policy making is that I'm constantly coming across excellent research providing a perfect answer to a question that no one had asked. And it's a real challenge if you're on the other side of the fence in getting answers to questions that really matter in policy making and in the direction of health policy in particular. So I'm going to leave those two gems from Yvette, get the problem, but what was the solution, and great research providing an answer to a question I hadn't asked. Just leave you to dwell on those for a little while as I run you quickly in 5 to 10 minutes in a process that actually took us nearly 2 years to get through, which began within days of the Blair government being elected in the late 1990s. He commissioned former Chief Medical Officer Sir Donald Acheson to undertake a review of how to tackle health inequalities in England, and he published a terrific report. And I've just picked out some of the really important headlines from this. Health inequalities, the gap in health inequalities, the gap in health status between the rich and the poor in the UK hadn't changed in 50 years. In fact, for the most part, it had got worse. Those differences are observable from birth to death, and it doesn't matter which form of indicator you use, they remain in place. He did, though, he made 78 recommendations all up, and I did ask him if he could reduce those to 5 critical recommendations, and he did so to his great credit. And none of these will be a big surprise to you. Families with children should be a priority. Reducing income inequalities would probably have the biggest impact of anything on health inequalities in the long term. This was something that was a whole of government challenge, not something that the health service alone could tackle. But when we think about the health services, 2 things he really emphasized. Firstly, the major gains will come from the health problems which occur most frequently. I know that makes complete sense when you think about it, but actually what happens when governments look to tackle health inequalities is that they immediately narrow their focus on small-scale issues rather than recognizing that the big gains are to be made in the biggest of the health problems. And the second complementary point is that things that improve health overall, on average, may have no impact on inequity, and in fact, in many cases, may actually exacerbate the problem. So universalism here is necessary, but it's not on its own sufficient to address inequalities in health. Some really profound and important principles that we were working with from the word go. Of all the evidence that I was able to muster to persuade the government to take action on inequalities, it's this slide that actually got people's attention. Nobody actually cared too much about the epidemiology. They'd been hearing it for decades. This was a slide showing the tube line, the Jubilee line, from Westminster to West Ham. And if you took that ride and you went through 9 stops on the way to West Ham, for each stop, you would lose a year of life expectancy. So by the time you got off from the seat of power in Westminster Station, underneath the Houses of Parliament, and you got off at West Ham 9 stops later, average life expectancy reduced by 9 years. And it wasn't hard to understand why. It's one of the poorest London boroughs. More than 50% of the population were born outside of London. Over 30% were non-English speaking as their first language. It was a very powerful slide to get people's attention. Anyway, cut a very long story short, over a 2-year period, I worked across government to develop an all-of-government programme for action. It highlighted 4 principal strategies. One was to try to attack the root causes of inequalities in health and to give primacy to prevention. Secondly, it wasn't about inventing new programs, but rather the focus was very much on working through the mainstream of society and government, and this meant that the NHS, the National Health Service in the UK, had a fundamental role to play. Thirdly, there were some deep-seated and highly specific problems that needed targeted intervention. And finally, that this would not be a single one-size-fits-all approach to tackling health inequalities, but something that would vary locality to locality in a way that sought to engage with communities. Those were the underlying strategies. There were 4 key themes. So it was a bit of a matrix as a strategy. Firstly, following the advice of the Atchison report, a very strong focus on families with children and addressing poverty among families with children in particular. Secondly, this concept of working with the grain, working with existing government programs through economic renewal and social exclusion strategies were paramount in this regard. Thirdly, this focus on addressing the underlying determinants of health, this required a whole of government approach. And then finally, preventing health and providing effective treatment and care in ways that actively addressed inequities rather than simply pursuing a path of universalism. And this focused attention particularly on access and management of the social gradient in modifiable disease risks in primary care and on health services quality and access across the country. Any of you who have ever been a civil servant will know how proud I am of this single slide here. Forget the content. I managed to produce a report that had a foreword by the Prime Minister and had the logos of 11 departments of government on the back of it, and a fully funded £8 billion programme across 11 departments of government to tackle health inequalities after a 2-year period, of which the role of the Department of Health and the NHS was essential, but by no means all that was required. In fact, the specific spend on tackling health inequalities through the NHS was not as much as the spend by other departments of government, I'd have to emphasise. So just to wrap up what we learned from all of this and what might have some implications for the way we think about health services research to tackle health inequalities in Australia. This work identified 3 key roles for the NHS in tackling health inequalities: a critical role in primary care, particularly for supporting preventive interventions, and also in primary care by ensuring that we connected through primary care patients in the NHS who needed services and access to services that weren't part of the NHS, becoming a point of connection so that people actually got the support they needed at the time they needed it. Secondly, it was a time of significant investment in the NHS, and one of the things we became extremely conscious of was that investing in more of the same would only result in continuation of inequalities. And so, although the phrasing wasn't used at that time, this idea of proportional universalism, investing where it was needed most to address inequalities rather than fairly sharing resources across the NHS, became a really important driver within the NHS. I'm going to come on to the implications for what we didn't know at that time. And then finally, an important role for the NHS in contributing along with other public services in local economic regeneration activities, bearing in mind the importance of economic regeneration, employment and education to improving inequalities in health. In terms of the critical drivers of the thinking behind this work, trying to get a better balance between prevention and treatment, and still are. Service provision has to be much more systematically matched to health needs. Honestly, first 50 years of the National Health Service, the profile of investment in health services barely shifted from the state that the health system was in 1948 when the NHS was created. It's extraordinary to imagine that, but the pattern of investment was basically the same as it had historically been for more than 50 years. There had to be some more direct intervention to shift that investment to where it was most needed to address inequalities. There were a range of much more targeted, locally based interventions that accounted for social, cultural, language and other ethnic needs in the population. And then finally, this notion that our goal overall in the NHS was to improve health overall, but to improve the health of the poorest fastest. A really challenging principle, I'd have to put it to you. Did it work? Don't have time to get into the evaluations, but I would draw your attention to this paper, which for me is probably one of the best efforts to capture what had been learned independently, by the way. This is nothing to do with government, by a group of independent researchers, including Margaret Whitehead, who might be known to some of you, published in 2017 after this program had run for about 8 or 9 years up until the global financial crisis. Long and the short of it is that they think they identified clear evidence to show the strategy for the first time in our health history in the UK actually led to a decline in geographical inequalities and life expectancy, reversing, as it says here, a previously increasing trend. Sadly, since the strategy ended, inequalities have started to increase again, and that remains the case in the UK. And it says there's much to be learned from approaching health inequalities in an integrated approach across government that others can learn from. So to finish off, what did I feel we learned from all of this? First thing to say is that there's no sense in us imagining that if we're serious about addressing health inequalities in our populations in Australia, that it's something that the health system can do alone. It's necessary for the health system to provide leadership, but it cannot, we cannot honestly expect to address health inequalities without a whole of government response to the problem. Second thing to say is, I was overwhelmed with the amount of research and information available to me that in ever more sophisticated and refined way helped us to describe our problem of health inequalities in the UK. And I'd have to observe we are in the same situation in Australia, where we have honestly, endless descriptions of the problem of inequalities in health between different population groups, and far too little research which actually directly investigates solutions to that problem. I've got 5 suggested health services research priorities that if the research had been available at the time I was working on this, it would have been a godsend, I'd have to say. Firstly, this challenge of exposing and understanding better the ways in which overall improvements in health frequently mask increases in inequities. So in the UK it's true, and it's true in Australia. We pat ourselves on the back because we see increasing life expectancy, and we fail to observe that we seem to be achieving that overall increase in life expectancy, and at the same time are observing increases in inequities in health. Understanding that issue and understanding its meaning for our health services, for me, is fundamentally important. And the converse of that, exploring the concept of proportionate universalism and how it can be applied in practical ways to the way in which we fund our health services, for me, is a fundamental challenge. It's the actual solution. If we observe overall improvements in health but increases in inequities, we've got to direct our funding differently. We've got to interrupt our current patterns of funding to make a difference there. Then some more practical issues. Firstly, developing and testing funding and organisational interventions that address some of our best known variations in healthcare in regions and populations with highest disease burden and poorest access. Fourthly, and this is something I can't emphasise enough, it starts right back to the Atchison Review. He said that if you focus attention on the worst off 3 or 5 or 10% in the population, you will not address inequalities in health. It's only by addressing those factors that have an impact on the poorest 35 to 40% in the population that you really get the momentum and changes in the mainstream services that make a difference to inequalities in health. So what approaches make a difference, not perhaps to the worst off in our society, where we can do targeted work, highly concentrated work, but what makes a difference to the next 30%? And finally, responding to context, something that I took with me from my experience in the UK is that our health system is a really important part of our local economies. And there are significant ways in which the functioning of our health system can have an impact on local economic development activities, and understanding and exploring that further, I think, would be very productive. The last comment I want to make, and leave you with this as a point of discussion, in all my observations, if you want to move from observing to engaging, it's incredibly messy and very difficult. It requires us to engage with complexity, and it requires us to be prepared to adapt, especially when you compare it to observational research. It almost always requires mixed methods, hybrid designs, and significant practical engagement from complex health organisations and health systems. I've learned that trying to describe this complexity and trying to develop defensible methodologies within the constraints of our established health research applications, systems and structures is challenging, and honestly, it's frequently unrewarding. What happens is that it becomes much easier for us to contain a research question so much that it actually becomes divorced from the realities of health services functioning. This is my, you get a perfect answer to a question that no one actually asked, or we revert to systematically observing rather than engaging with the problem itself. So I'll leave you with those thoughts, but those were some of the challenging things it would have been nice to have known more about in terms of how our health systems function at the time we were trying to develop a response to health inequalities. I'm going to stop sharing now, I hope, and revert to Anne.
Thank you very much, Don. That was a just extraordinary talk, inspiring but also challenging. And it seems to me the inequities you're talking about, we've heard a lot about how they are worsened by the pandemic, and we can anticipate worsening with the impacts of climate change over the coming years. And so I think these are hardly problems that are going away. We've got some great questions in the chat, so I'll just take them in order and hope we can get through a few of them before Rachel or Alison tells me that we have to stop. The first is from Mitchell Sarkis. I've often heard this quote about the perfect answer to the question no one asked. Is there a good example of this you can talk us through? And does the problem not also rest with those uninterested in important questions? Don.
I immediately muted myself. Force of habit, I should remain quiet at all times. So firstly, the answer to your second question is yes. The problem does also rest with those who are uninterested in the important questions, and we should do more to make them interested in the more important questions. So simple answer to that one. For me, I'm going to have to give a sort of public health type answer to that question. I, in the earlier part of my career, was very involved in research on tobacco control and did my share of randomized trials of very highly defined interventions in schools and smoking cessation interventions. That in order, I'm sure this wouldn't happen today, so this isn't about the NHMRC, Anne, but in the UK at the time of my early stage of my career, in order to get funding, I had to so narrow down the research question in order that I could create a manageable randomized trial in order to answer it, that by the time I got to the end of the trial and got the answer to the question, its practical application was extremely limited and sort of missed the point. And I think that's really what I'm getting at, is that if we so narrow the focus of the research question that we're looking to answer, whether that's in clinical care or in prevention, that it becomes divorced from the practical reality, its potential practical application, then the learning from it becomes extremely limited. The other side of that coin is that, of course, as you expose yourself to the practical realities of implementation, your ability to control the research question becomes very challenged. What I was trying to highlight was that that's a delicate balancing act for research funding agencies, and my observation is that we're our own worst enemies. Our peer review process is what often drives us into narrowly focused questions. And I think Anne's appeal towards the end of her presentation, which was get involved as peer reviewers, is a very decent response to that. If we have basic scientists reviewing health services questions, it's not surprising that they bring a particular framework for thinking to that. So a real challenge in all of that, I appreciate.
Yeah, thanks, Don. The second question comes from Rachel Morton, and it's, can you comment on the integration of NHS primary care and specialist or hospital care in the UK to tackle health inequalities? What lessons could Australia and New Zealand learn from this UK model with respect to health services research?
Yeah, good question. So first of all, New Zealand have a bit more of an integrated health system than we do in Australia. Honestly, we are criminally constrained by our incessantly divided healthcare system in Australia. So one of the things, it's very hard to get integrated care. I'd have to say, I mentioned I'm on the board of a local health district, the Western Sydney Local Health District, which works as closely as is possible with its local primary care network, and with great support and at some cost from the state ministry to try to deliver much more joined up integrated care. And it's a fantastic experiment that we're trying to evaluate properly, but it's against all odds, because structurally our health system, such that it is in Australia, is so badly designed to achieve that level of integration. And one can only hope, and I do hope, that the kind of dialogue that I know is taking place nationally about future funding of our health services leads us more down the route of supporting integrated care than it does at the moment. But for me, that is the way forward, and honestly, the only way that we'll ever create a sustainable healthcare system in Australia. I suppose if I think across to what I know a little less about the system in New Zealand, but I do know that the opportunity for integrated care is much greater, and we've been learning a lot from some of the good examples of integrated care in New Zealand in the work that we're doing in Western Sydney.
Thanks very much, Don. Now let me just find this. We've got time, I think, with
one more question, I think, Anne. Yes.
Yeah, exactly. One more question from Megan Campbell. If there are concerns that the current policies are reversing the impact of previous policies, is there anything in particular? Because we're out of time, just a quick one, I think. Thanks, Don.
Sure. So I think the reference that I made was reference to the work that had been done in the UK, and a lot of that relates to the UK's response to the global financial crisis, which was to reduce investment in public services by about 30%. And this had a phenomenal impact on income support. So it increased poverty. And I would say that alone reversed the progress that had been made in the previous decade.
Yeah, well, that's a very striking comment. Don, you've given us a great deal to think about, superb talks, superb discussion. So thank you again. And it's now my job to hand back to Alison, I believe. Thank you.
Thank you.
Wonderful. Thank you so much, Don. That was really fascinating, and to you as well, Anne, for your time this morning and your presentation. It's been a really great morning session. So we've now got about 45 minutes for lunch. So we'll be coming back here, same Zoom link this afternoon. It'll be 12:45 p.m. Sydney time, which I think is about 9:45 a.m. for those who are joining us from Perth, and 2:45 for the, 9:45 for those people joining us from New Zealand, and 2:45 from WA. So maybe go outside, have a stretch, grab something to eat, and we'll really look forward to coming back for the afternoon session. Now, there's also a lunchtime session happening for those who are interested. Our Health Services Research Association of Australia and New Zealand mentoring program is currently open for applications for next year. So if you're interested in either being a mentor or a mentee, then come along to the lunchtime session. It's going to start in 10 minutes, so you've still got time to go and quickly grab something to eat and have a bit of a stretch. And I think Tilly or Sarah is going to put the link for that, which is happening in a separate Zoom room in the chat, so you can just click on that. There'll be a quick panel discussion with some previous mentors and mentees from the program, and we'll also be launching the 2022 program. So if anyone has any questions, feel free to put them in the chat, but otherwise we'll see you back here in about 45 minutes.
Sarah, we've just had a question in the chat from Brenda Roseleys about a link to the mentoring session. Thank you.
Yeah, it's in there. I just a couple of chats above hers. I've just attached the
perfect. She has it.
The link there and the password. Let me know if you have a problem with that.
And it might be worthwhile setting up the breakout room, Sarah, that we mentioned earlier. I think people will be hanging on in this room and then just rejoining their laptops when we resume.
Yeah, this is just Marsha, Somi, if you're online, and Rachel. I'm just going to create a breakout room and just for us to join and just test.
Thank you.
Your slides, etc. I'm having such success with. Can you see that breakout room, Rachel?
No, I don't think it's coming up for me.
Are you online, Marsha? Would you like to switch on your microphone and video just briefly? I'm not sure that Marsha is online anyway, Rachel.
Okay. All right. Perhaps if you could send her a message by text or email. And I'll be back in a few minutes.
Yeah, sure.
Sarah, I'm just going to pop and grab some water and then I'll join the mentoring session.
Yeah, thanks. See you.
Okay, see you.
Through a wide range of funding mechanisms. Before I begin, I'd just like to briefly acknowledge conference organisers, particularly Alison Pearce, Sarah Green and Rachel Morton for their support in having HSC involved and for putting together such an engaging program. So I will now attempt to hopefully smoothly share my screen. Sorry.
That was all good.
Could you see that?
Yeah, just share your screen and then I think if you click on slideshow, you should just get the one.
Ah, perfect. Yes, thanks for that.
Oh, yeah, that's it. Yeah.
Somewhat smoothly. Cool. So a brief presentation to give, which we'll talk a bit about what HRC is doing regarding equity in our processes. So just a brief overview of the presentation to start with. I'll start by talking about what contributing to supporting equity means for the HRC and give some brief examples of what this looks like at a funding round and process level. So what does equity mean for the HRC? So in Aotearoa, New Zealand, health equity is becoming an increasing focus of legislation, government health research policy and health system reform. And as a government agency, our plans to champion equity must centre the rights guaranteed to Māori in Te Tiriti o Waitangi, or in English for Treaty of Waitangi, this being Aotearoa New Zealand's founding document. So we recognise that advancing health equity requires a particular focus on Māori health. The link between social equity, Te Tiriti justice and health is well documented and advocated for in Aotearoa. For example, both the recent Y2575 Health Services and Outcomes Inquiry and the Health and Disability System Review provide evidence of the health system generating and perpetuating inequitable health outcomes for Māori. And so as funders of health research, the HSC has a real opportunity to make a significant contribution to health equity through the health research we fund and the research workforce we support. And as an organisation, we acknowledge we are on a journey to being a good Te Tiriti partner in embedding equity in all that we do. And while there's a lot more for us to continue to do, as an organisation, we have taken some positive steps in the right direction, and I'll talk about some of these briefly now. So how are we prioritising equity in our work? First of all, I note the HSC Act puts us in a relatively unique position as a Crown agency in Aotearoa in having a statutory Māori Health Committee that provides advice and strategic direction with regards to Māori health. And the Māori Health Committee has had a key role in driving and developing the HSC's response to improving health equity, including the following points on the slide, which I will now talk about over the next couple of slides. So the HSC now has Māori Health Advancement Policy guiding our research investment. And as part of the implementation of this policy, we developed Māori Health Advancement Guidelines to support applicants in responding to this aspect in their applications. And in responding to Māori Health Advancement, applicants are asked two key questions. One, how will the outcomes of the research contribute to Māori Health Advancement? And two, what activities have already been undertaken relative to their work and what will be undertaken during the course of the project? Māori Health Advancement is assessed specific to the context of the research being undertaken, whether it be public health, clinical or biomedical as examples. We are progressively implementing Māori Health Advancement across all our investment with the intent that all research funded by the HRC is assessed on potential to advance Māori health. And we are continuing to seek feedback to improve the process in future rounds. And I know so far we've had some feedback from our committees about the positive impact that they have seen Māori Health Advancement having and shifting response from the research community. I've highlighted here just a couple of recent targeted HRC funding rounds that had a strong focus on equity. Firstly, the COVID-19 equity round, which had a total funding pool of around 8.3 million and included ring-fence funding for research that was Māori-led and that led to equitable health outcomes for Māori. And secondly, the Equitable Cancer Outcomes round, which was a three-way partnership between the HRC, the Cancer Control Agency and the Ministry of Health with a funding pool of around 6.5 million. I'll now talk very briefly about the HSC's Health Delivery Research Investment Round, which may be of interest to some of the attendees today, through which we support research that seeks to directly inform changes to policy, practice or systems in Aotearoa. So in 2019, we redesigned our health delivery funding and relaunched this as its own standalone round with multiple grant opportunities. And a key focus and consideration of this redesign was how to prioritise health equity and Māori health. And we were guided by two key documents, the New Zealand Health Research Strategy and the resulting prioritisation framework, as well as through consultation with the sector. And just to note for those interested, I guess mainly the New Zealand attendees, the next round, health delivery round will open in February 2022. So being intentional about centering equity of health outcomes has meant that each part of the process for this health delivery round has equity considerations embedded within them. And just to touch on a few examples, firstly in the investment signal, there's a strong focus on equity and health and wellbeing of Māori and Pacific peoples, led by Māori and Pacific researchers. through the criteria weighting and scoring. For example, the health delivery project grants are assessed against the Māori health advancement, but also the other criteria have a strong focus on achieving health equity. And for our activation grants and career development awards, there is an increased weighting on the Māori health and equity criterion. And through the assessment panel for this round, we've ensured a diverse panel membership, which includes 50% Māori membership, as well as a Māori co-chair. And finally, through ongoing evaluation and monitoring. This includes continuing to develop future opportunities that centre equity, for example, opportunities targeting Māori and Pacific health sector providers. So I'll leave it there and just finish by saying that HSC has a history of funding important research that has contributed to improving health equity, and we are really driven to see this continue to grow through ensuring health equity is at the centre of what we do. Kia ora, and thank you. And
thanks very much, Luke. Would you like to introduce our second keynote speaker?
Absolutely. Just to check, I've stopped screen sharing, I hope.
Yes, you have.
Yes, excellent. Great. So it's a great pleasure for me to introduce this session's plenary speaker and someone who is a champion of health equity through the research she undertakes, and that's Dr. Amohia Boulton. So the HSC has a history of supporting Amohia's work, starting with an initial HSC Māori Health Training Fellowship awarded to Amohia in the early 2000s, right through to a $5 million research program grant awarded earlier this year, which Amohia will talk about shortly. Amohia is the Director of puawai Research Services, which is an iwi-owned and mandated health research centre in Whanganui, New Zealand. She is an adjunct professor at both the Health Services Research Centre, Victoria University of Wellington, and in the Faculty of Health and Environmental Sciences at Auckland University of Technology, and she's also a technician to the National Iwi Chairs Forum. Amohia is a kaupapa Māori health services researcher with some 20 years experience and having undertaken her PhD after a brief career as a public servant, working in the fields of education and Māori development. And as a result of that policy experience, Amohia has an enduring interest in the relationships between and contribution of government policy to improving wellbeing outcomes for Māori, and much of her research work focuses on this intersection. And most recently, Amohia contributed to an independent report examining the interface between science and particularly Indigenous knowledge and policy making at the national level, which called for greater support for Māori knowledge, Māori leadership and Māori decision making in the New Zealand science system, themes which are echoed in the HSC program grant that Amohia and the whakauai team were awarded earlier this year. And Amohia's program grant is titled Kia Puawai Ake Ngā Uri Whakatupa, Flourishing Future Generations. And just before I hand over to Amohia to talk about this program, just a reminder there'll be a short Q&A session after Amohia's talk, so please enter any questions you may have in the Zoom chat. I'll keep an eye on this and we'll be able to ask Amohia some of these at the end. So kia ora, Amohia, over to you.
Kia ora, Luke. Hopefully I'm screen sharing my slides.
Yep, looks really good, Amohia.
Ka pai, thank you. Anei, toku waiata. Taku tūranga tonu au e noho ana. Ia tau. I waenga awa ko ka whatau, ki te ngatu awa ki rangi tike. Mai te pātu wata ko te kaupota, ko haukaha. Mai te kainga wai ko te awa hai, ko tautahi. Ko ngā tūpuna moko puna o ngā tihau iti. Nui tonu rā. Ko ngā uri e whai ora nei te maumaharatanga. Ko ngā pau o na mata. Rere tonu atu rā ki te pāpapa kai ngō te iwi. Ko tara, e ka rangaranga na mai, te tupuna e moe mai rā. Ko tāpui, ko te moe moe a o te honga noho noho I te ai o tanga. Kia puawai ake ngāuri whakatupu. Tēnā koutou ku whakarauka mai tēnei apa, ki te whakarongoi, ki tēnei kōrero, mātua he mihi atu ki ngā tangata whenua o ia wāhi, o ia wāhi, o ia whenua, o ia whenua. Nei rā te mihi mahana ki a koutou, mō koutou manaaki mō ngā puna mātauranga hoki. Ko waio, he uri ahau no tauranga moana, ki te tau tōku māma, me taranaki maunga ki te tau tōku pāpā, ko Amohia Boulton tōku ingoa. So, good afternoon and welcome to this presentation. A little bit different from Don's, but there's lots that Don said which really resonated with me, which I hope I can bring forward in this presentation. So really excited to talk to you about our program grant, and thank you for the opportunity. Before I start, I wanted to thank the Health Services Research Association of Australia and New Zealand for this end of year event. Most of us who have been in the association for a long time really look forward to our biennial conference, and so I'm really pleased that we've got something in this year that was meant to be our conference year. So thank you to Rachel Morton, to Alison Pearce, and to Sarah, who's always working really hard in the background. Yeah, thank you for this opportunity. I thought I would start with this little set of pictures. For those of you who don't know anything about whakauai research, and there's probably many of you who don't. As Luke said, we are an independent research centre that is wholly owned by the iwi of Ngāti Hauiti. So we sit outside the academic tertiary institutions. We're completely independent, owned and mandated by the iwi of Ngāti Hauiti. For those of you that know the North Island of New Zealand, Hauiti are located in the lower middle part of the North Island. It's a very small iwi, only some 3,000 people, and they have a very strong history of acknowledging the need for Western and Māori knowledge working together for the health and well-being of the people. For whakauai's point of view, we conduct a range of health services, health policy, public health, community health, research and evaluation from a kaupapa Māori perspective. So from a perspective that privileges Māori knowledge and ways of being. We are completely accountable to the tribe, and we operate according to a set of guidelines or values, our tikanga, that come from that tribe. Our vision is to transform Māori lives through excellent research. We are wholly self-funded, so we really, really value the Health Research Council and the opportunities that it affords us. And we've got a track record of being fortunate with getting grants from the Health Research Council since our inception, which was back in 2005. We were founded by Dr. Heather Gifford, herself a tobacco control researcher, and I'm pretty sure I remember Don's name from some of the tobacco control work that I had to read back then. Many of you will probably know Heather. We have a team of approximately, well, as of today, 9 people. Heather has finally initiated her retirement and has exited from our centre, although she is subcontracting into this program. So we have 9 researchers, 9 staff members, 5 of whom are researchers, and we've got an admin team of 3 headed by our business manager, and we have a new person, a recent appointment, who's our design lead, who kind of sits between the two and is himself doing his PhD. And that's kind of important for what I'm going to talk about later. So this, and the remaining time that I've got, is what I'm going to cover. I'll talk about our program grant, why this program grant, why now, the conceptual framework and some of the foundational principles for that program grant, the structure of it, and talk a little bit about this idea of translation, uptake and impact. An approach that we've been developing over a number of years and which through the program grant we really hope to make steady gains with. Let me see. Okay. The impetus for this grant were many and varied. So as Luke said, we got the grant in July of this year. We are now officially 1 month into the grant because we delayed the start of it until the 1st of November. So we've been going for exactly one of our 16 months. You'll know, the health researchers amongst you, you'll know that, you know, something like a program grant is a long time in the making. So when I think about what was going on when we were drafting this grant, that was about March to June of 2020. So we were right in the middle of our first COVID lockdown. If I cast my mind back to that time at a national level, as Luke has also alluded to, we had the National Health and Disability System Review was underway, and they had released their final report in March of 2020. One of the things that that review acknowledged was that there is a need to reform the health system to better address health inequities, and in doing so, we have to do so in a way which provides for a greater role by Māori as treaty partners. Possibly less well known by many was the fact that there was also, throughout 2019, an urgent contemporary claim to the Waitangi Tribunal, the so-called Health Services and Outcomes Kaupapa Inquiry. That was a claim brought against the Crown regarding the legislative and policy framework for the primary healthcare sector. So effectively the claimants were arguing at the tribunal that the existing frameworks for primary healthcare had failed to achieve Māori health equity, and that framework was not fit for purpose. Also at that time, as I've alluded to, we were right in the middle of COVID-19, and I guess from our perspective as a research centre that is owned by iwi, by a tribe that is deeply ingrained within our community, what we saw occurring for us was this rapid mobilisation on the part of our Māori health providers to support and care for our whānau during that lockdown. So they effectively stepped into a vacuum that, you know, our Crown agencies weren't able to provide support and provide for the needs of our whānau in that time as rapidly as they needed to. So initially there was a huge vacuum and Māori providers were stepping into it. At that time too, and again, Don spoke about this need, if we're going to address health inequities, to think beyond and to be beyond the health system, that we need an intersectoral, collaborative, integrated approach across government departments and sectors. So another thing that we were seeing while all this work was going on in the health sector, similarly other reviews were occurring in the justice sector, in the child protection sector, in the social welfare sector. And through all of those reviews, a common thread, a common theme was that Māori were demanding greater voice and greater partnership and a role at decision-making tables and greater leadership really on the part of Māori. So that was kind of what was happening in our national, the national context. Looking internally at whakauai, for us, the timing for a program grant was perfect really, because after this kind of track record of research, we had grown some skills and some expertise in particular areas, one of which happens to be looking intersectorally across different sectors to see how they can inform, enhance, support Māori wellbeing. We knew that the time was right for us to pull those threads together in some cohesive manner in something like a program of research. So those of you definitely in the New Zealand sector, and I'm sure there's a similar thing in the Australian context, one of the beauties of a program grant is that it gives you a 5-year time frame for a start, and specifically provides for the long-term development of a health research field, where a team has a strategic vision, and for us that strategic vision has to contribute to improving the health outcomes for all New Zealanders. So yeah, internally for us, the timing was perfect. And then given the context, it really was a perfect storm for us of now is the time for us to go ahead and apply for a program grant. That is looking effectively at how we address inequity, or in fact, create equity of health outcome. So, unfortunately, you got me singing a song to start this presentation, and I didn't do it because I've got such a wonderful voice, clearly. I did it because, as the director of puawai, if we were going to put in a program grant, what I knew we had to do was put in a program grant that was based on, foundationally, our mātauranga Māori, our Māori knowledge. It had to come from a position of our understanding, our knowledge, our ways of knowing, our worldview. And so the cracking the program grant for me was really about finding a conceptual framework which would be able to carry what we wanted to achieve. And that conceptual framework is in that waiata. That waiata is effectively our conceptual framework. So that waiata was written in 2003 by one of the tribal leaders for Ngāti Hauiti. And what the waiata does is take you on a journey down a river. So you'll know potentially as Indigenous peoples, our landscape, our land, our rivers, our mountains, our waterways, our seas, these are all important to us because we see ourselves as having a genealogical connection to those things. So when we introduce ourselves, we normally introduce ourselves by talking about our whenua, our land and our mountains and our rivers. This, the river that is most sacred to the people of Ngāti Hauiti is the Rangitike River, which is the kind of the big river in that image. This waiata takes you down that river. It's a journey down that river, passing sites of significance along the way. And this is one of those sites of significance, which is the meeting of the waters. So here is where the Rangitike River and the Kawhato stream meet. And this is a particular place of interest and importance. In our program grant, what we've done is we've used this meeting of the waters as an analogy for the two streams of research inquiry that are brought together in the grant. So the first stream of research inquiry, stick with me on this, it's really important. The first stream of research inquiry is founded on mātauranga Māori and a Māori worldview and advances the agenda that Māori have for our own well-being and focuses on our own development and advancement as Māori. The second stream represents our role, the second stream of research inquiry, represents our role as Māori within a predominantly Pākehā or mainstream system and how we engage with that health system at a number of levels. And then how we as partners within that system want to contribute to the achievement of equity of health outcome for our people. So those are the two streams. You can think of it another way if you could apply a Treaty of Waitangi analysis to that and think about it as the first stream of work under the program grant is concerned with those things that uphold our Article 1 and Article 2 rights as Indigenous people, as Māori in this country. So research questions that might not be of any interest to anyone else but are of critical interest to us flourishing as Māori. The second part is of our program grant is concerned with our Article 3 rights. So those rights that must be upheld are those rights that we can expect as citizens of a country under Te Tiriti o Waitangi. So that we should expect health outcomes that are at least equal to any other citizen within this country. Then the final thing, obviously, through that waiata, is that right at the end, there is the final line is kia puawai ake ngā uri whakatupu, which talks about the knowledge that people, that Hauiti have, that there is ancient knowledge, that there is contemporary knowledge, and that the tupuna, the ancestors, the thing that they seek the most is that in the future, the people of Hauiti, Māoridom, will flourish into the future. So that's how we get our title, Kia puawai ake ngā uri whakatupu, the flourishing of future generations. So once we had that conceptual framework, it was, relatively easy to then slot the work that we wanted to do within that framework. And I've touched on some of these things as I've talked, but there are a number of underlying principles which form the foundation for that program grant. And I would say that the grant is different to most other, and Luke could correct me if I'm wrong, most other program grants that might come out of particularly university or mainstream settings. So one of the things that we contend is that equity of Māori health outcomes is essential for the wider social and economic wellbeing and advancement of the country. The inequities that exist in Māori health outcome will only be reduced when Māori are able to exercise rangatiratanga, or leadership, and self-determination. It will only occur when Māori exercise power, control and autonomy over their own health and of that and the health and well-being of the collectives in which they exist. That Māori must develop and lead their own solutions, and that the Crown must work with us in an authentic partnership model to achieve those outcomes or those objectives. So as kaupapa Māori researchers, we see the solutions to our health and well-being lying within our hands, not in the hands of the Crown as our treaty partner, nor in the mainstream health system as it's currently configured, which is pretty much what both the Health and Disability System Review and the Waitangi Tribunal Health Hauora report concluded as well. The catch, of course, is then how do we improve the health system to better meet the needs and aspirations of Māori, whānau, hapu and iwi. So what new insights and evidence are critical to create the conditions necessary for a shift in the system, in the health system? A shift where the actions that we want are resourced appropriately and are targeted effectively to achieve equity of health outcome, and which then will help realise our aspirations that we flourish as Māori. And so that's the challenge we've set ourselves with the program grant. It was interesting listening to Don talk about who asked the questions, where do the questions come from. So for us, the questions come from our people. They come from Māori, and not just the overarching program question, but the questions that run each of the projects within the program. So I'll talk about that. The other thing I wanted to touch on too was that idea that universalism will not work, and I just wanted to reiterate that clearly for us, universalism hasn't worked. Both the Hauora report and the Health and Disability System Review acknowledge that, and so we need to do something different. So the overarching question for us is what knowledge is required to shift system responses to enable better health outcomes for Māori. And I wanted to point out that when we talk about systems, yes, we are talking about the health system, as probably the primary system that we think about. But we also have a view that whānau, so Māori families, operate in a number of different systems. So the whānau itself is a system, the sub-tribe is a system, the collective that is the tribe, the iwi, is a system. So that means that there are a number of systems within which whānau are operating, one of which is the health system, and that provides us potentially with the opportunity, with a number of opportunities or a number of levers where we can make some change. So yes, we are looking at the health system, but also what can we do as Māori within our own collectives that will help support our health and well-being and our shift towards equity of health outcome. Underneath the overarching question, we have a couple of aims: to generate new mātauranga Māori, or to generate new Māori knowledge, and to create systems of knowledge translation that facilitate the uptake of key findings so that we can improve health outcomes for Māori. So structurally then, you can think of the program as four components or objectives, 3 of which are dedicated research projects, and 1 of which is our translation, uptake and impact stream, so our TUI stream. And then 1 long-term goal over and above or aligned to our existing program goal, which is the achievement of pai ora. And pai ora has come to mean, in this country, healthy futures. It is the overarching goal of our health strategy for Māori, and it is about to be forever enshrined in our psyche, because it is the name that has been adopted for the legislation for the reforms that are currently underway. So pai ora should certainly be at the foremost of the health sector's mind. So again, these are our 3 research projects. Most of what, well, they are either building on previous work that we've already done, or they have come about because our community have asked us to research these things. They have been identified as areas of importance for different parts of our community. So I just want to touch really briefly on each of these. The first project, Rapua Te Ara Rangatira Kia Hikitia Ai Te Oranga Tangata, is a project that is trying to understand the role that iwi will play, so tribes will play, in the leadership, governance and decision making that will occur in a reformed health system. So as part of the health reforms, we now know that iwi Māori partnership boards will be established, and the role of those boards is to assist in setting local priorities in their region, and will work very closely with the 2 major organisations that have been established, Health New Zealand and the Māori Health Authority. We know that as Māori, our skills and experience and knowledge in Western mainstream governance has increased in the last 30 to 40 years as we have undergone a process of settling historical breaches of the Treaty of Waitangi with the Crown. And so many iwi are now very good governors, very good stewards of post-governance settlement entities, so large economic entities that are investing and managing treaty settlement money on behalf of their people. So we know that in one sense there is a very strong governance and leadership expertise within our community. However, if we look at the health sector, the issue of leadership and governance is more vexed. So this project is going to explore what iwi members need to actively and effectively participate in the leadership forums that are being established. And we are seeking we will create and develop a model of governance which will be trialled by our tribal council in I wish it was week, in year 3 of our project. And that piece of work has been specifically requested of us by our iwi owners, by Ngāti Hauiti. The belief being that if we can raise the skills and expertise of our governors at a tribal level, they will be better positioned and better placed to work in our iwi Māori partnership boards and affect the decisions and the changes that we need to see happening on the ground for our people. Project 2, Tō Mātou Kāinga, Tō Mātou Ukai Pō, is a project which is looking to understand whānau understandings of the concept of home. So what does it mean to be safe and well in your home? And this has become even more relevant given what's happening with COVID, what's happening in this country regarding over successive lockdowns. We've been told as Māori to stay within our bubble, to stay within our house, but how do we, and there is an assumption that we can be well and safe when we do that, but that's not necessarily the case. And for Māori, the notion of home evokes concepts. It's not just a physical dwelling. So when we think about home, we think about our connectedness intergenerationally to our family members, to those past, present and future, to our connections to the land. And the home is a place not just of physical well-being, but should be a place of mental, emotional and spiritual well-being as well. So, we have evidence to suggest that, we can't even, or we don't even at the moment, have a housing stock, a physical housing stock that is keeping us well, let alone a housing stock or a home that is keeping us well on those other dimensions of well-being. So this project is going to work with whānau to understand what home means for them. And our aim in this project is to develop a series of safety and wellbeing indicators and resources that whānau can use to enhance their safety and wellbeing at home and within their own communities. Project 3, He Waka Eke Noa, this is the project that the health boffins love, because this project is being undertaken in partnership with a local primary healthcare organisation. The project seeks to find out how we can increase Māori access to primary healthcare in the pre-diagnosis phase of cancer. So we're going to be working with both whānau, so families and clinicians, to identify the changes that are required in the health system, as a system, in the primary healthcare system, but also that might be required amongst our collectives, amongst our Māori systems that I talked about. So what changes are required that will help ensure earlier diagnosis and therefore earlier treatment of cancer for Māori? And again, this project came about because one of our local primary healthcare practices, one of our local GPs approached us to undertake this work. He was dismayed by what he was seeing in terms of health outcomes around cancer, cancer treatment outcomes for Māori. And so he and his practice have made a commitment to us that in doing this research, they will enact the findings of the research and make on the ground changes within their practice to move us towards that better state of well-being, towards an achievement of health equity for Māori. So that's the 3 research projects. Now, I am very aware that there is an infographic competition, but anyway, here are our infographics designed by our young design lead, who we just love because, trust me, our researchers can't do this sort of stuff. What the purpose of the infographic is to describe our TUI approach, our translation, uptake and impact approach and framework. This was an infographic that we developed to give to our TUI advisory board, who are helping us to take our research findings and make sure that they make the greatest impact possible. So just on the left-hand side is some information, high-level information about the project, about the program, sorry. And then all those other points on the page are the actions, the activities, the outcomes that we want to see as a consequence of the program grant and as a consequence of enacting and being very mindful and very considerate about how we seek to disseminate our research, the methods that we're using to disseminate, how we become timely, relevant and engaging with our research. So this is my last slide, roughly. You notice. In 5 years' time, the Health Services Research Association might invite me back to find out what we did in the 60 months prior, what we did with our program grant, and whether in fact we met all those high level objectives and challenges that we set for ourselves. At the very least, these 3 points that I pulled out from the slide before, I think we should be able to nail. So by the end of the program grant, by the end of the 5 years, I would expect that we have definitely created new Indigenous knowledge, new mātauranga Māori, that has been able to inform the very real and very rapid changes that are currently occurring within our health system, and that have been able to inform our iwi hapu whānau. I would also expect that at the end of the 5 years, we have informed decision making, the decision making that's occurring at multiple levels, whether it be within the health system, whether it be in the national iwi space, whether it be down in at a provider level, or even within our iwi Māori partnership boards. I would also hope that the information or the evidence that we produce is able to inform the discussions and the debates that are being had at Health New Zealand and with the Māori Health Authority. And then finally, we should have explored novel ways of disseminating our research so that we can do so in a way that is much more timely, that informs all these processes that I've talked about above. Because at the end of the day, it is for us all about advancing our aims of flourishing into the future and how research can assist us to achieve that aim. Nō reira, i ngā kai whakaoko, tēnā koutou, tēnā koutou, tēnā koutou katoa.
Kia ora, Amohia. Thank you so much for that incredibly engaging and interesting presentation. Great hearing about this unique piece of research and what is an incredibly important research. I guess from an HSC perspective, it makes me proud to be working for an organisation that has been able to fund it. So thanks again. I'm conscious of the time. I think maybe you could quickly squeeze in one question before handing back to Rachel or Alison. I had one just off the bat, if that's all right. I know you talked about the timing of this grant in terms of what was going on in the wider sector with the Health and Disability System Review and the Y2575 report and some of the broader reviews in other sectors. I note that the timing from when you submitted your application, since then there's been the announcement around the health system reforms, and I just wondered whether, and you referred to that in terms of the work you're doing, but whether that has been a benefit in terms of providing further opportunities for the work that you're doing, or has presented challenges, given that that announcement had sort of come after you had done the initial submission and work?
Oh, kia ora, Luke. No, it definitely provides opportunities. I think, so one of the things about the program grant process is that you undertake an interview as part of that. And it was really interesting talking to our interview panel, because by the time we got to the interview stage, the reforms had been announced. And if you read our grant, it pretty much was like reading the health, the messages of the health reforms. So it almost gives us even more impetus, I guess, that we know that we're on the right track and what we're thinking. We know that we have thought about the levers that we need to move, to play with, to influence and to inform. And as part of the grant, what we did was strategically set up our TUI advisory board, so our Translation Uptake and Impact Advisory Board includes members who are very integral, shall I say, to what is happening with the health reforms. So we while they are giving us advice on how our research evidence should be used, at the same time we are hoping that the evidence that we produce is able to be fed back through them so that then they can use it in the forums and where they are operating. So yeah, the timing I think couldn't be better for a grant like this. And clearly, you know, if I refer back to the issue around peer review, our peers who reviewed this application thought so too. So there's huge expectation, I guess, is one of the downsides, but yeah, it's so overdue that we do this work, really.
Cool, thanks. No pressure.
Yeah, no pressure.
Great to hear that alignment, and that was sort of already there before the system reforms were actually announced. So it's really cool. Yes, I think it's time for me to hand back to either Rachel or Alison. Rachel?
Thanks. Yeah, thank you very much,
again,
Luke.
Amohia.
And thank you so much, Amohia. It was an absolutely fantastic presentation. And if you have time to look at the chat, you'll see some personal responses to your talk. So I'd just like to thank you very much for telling us about your planned research and also drawing on a lot of theory.